hypertension was well controlled. We had a conversation, but I'm curious after this, what other things I ought to have considered with her.
So it's polycystic kidney disease, and what else? Hypertension, you said?
Hypertension, right.
Yeah.
And currently her kidney function is normal.
Currently normal.
GFR is normal.
Yeah, that's a tough one. You're right. You know, it's always a risk-benefit issue, as you already rightly pointed out. And in an ideal situation, she should be protected against stroke, anticoagulation. And you said that she's high risk for bleeding. She had bleeding issues already.
Yes.
Yeah. So that's a patient where we have this new paradigm developing, and there's a technique for left atrial appendage closure. It's something I think Dr. Phelan's going to talk about a little bit later. There's a device called the Watchman device that's gone through clinical trials compared to warfarin, and has been shown to be non-inferior to warfarin for preventing stroke, especially in patients who may not be able to feed on anticoagulation. This kind of patient may, it sounds like falls into a category where we're concerned enough about anticoagulation that we would, say she's probably not a good candidate for blood thinners. What else can we do in this situation? That's something that we would start thinking about. If you guys want to add anything.
I think that's spot on. I think none of us have a crystal ball. So if she has a stroke, you chose wrong. If she has a major bleeding episode, you chose wrong. So you just have to have a discussion with them. You can go through the has blood scoring system. The problem with that is that it ultimately invariably shows the same risk of bleeding as the chest tube vasc because there's such an overlap of those risk factors. So I don't find it all that useful in most situations. If they've had significant bleeding, not just epistaxis during the winter months, they're not using a humidifier, or a touch of hematuria, you may still want to consider a trial of perhaps Coumadin, targeting an INR very close to 2, and prove that they are going to have a bleeding problem, especially if you're getting a bit higher than 2 in the chest vasc 2 scoring. But I think the Watchman hopefully will be a good alternative to mitigate some of their risks long term.
Okay. I have a question that's directed to Dr. Kelly. I'd like to get a comment from her. My wife has an aunt who's 75 years old. She had non-ischemic cardiomyopathy, and last year her ejection fraction was 35%. And she's getting an ICD today in Milwaukee. She did not want the ICD because she says she has anxiety. There's something inside her body connected to her heart. But her cardiologist told her that if she did not get the ICD, he would no longer be her cardiologist. I just thought it was key.
I think she should fire him. And that's ridiculous. No physician should refuse to take care of a patient just because their wishes may be different than what yours are. But I mean, the bottom line is if you have a 75-year-old with a non-ischemic cardiomyopathy, her risk of having a life-threatening arrhythmia is about 1 in 20 over the next 5 years. So the benefit from an ICD in somebody as they get older also diminishes. So one, the benefit to her is going to be reduced anyway, and two, what an insult to give a patient a therapy that they are not going to enjoy. It's going to be a long-term problem for her. I think that's absolutely terrible. I'm sorry.
Yes, actually, dovetailing on Dr. Phelan's question of the 46-year-old lady with, I've had this kind of therapeutic dilemma in my practice also. What I would do, and correct me if I'm wrong, I would send this patient to Patel or Kartik to consider ablation of the atrial fibrillation because she's 46 years old. It could be paroxysmal, it could not be as permanent as one would think. Under the cover of any anticoagulant like Dolonox or whatever, and we can always give her blood transfusions if she gets anemic enough from the hematuria of the polycystic kidney disease, because I think stroke is a much more permanent, debilitating problem. Anemia can be treated, and so can the atrial fibrillation. What are your views on this kind of a treatment regime? Okay.
Yeah, I think it's not an unreasonable approach. I think patients that do have some bleeding risk and are having symptomatic atrial fibrillation, because you consider fibrillation, The caveat being that in the short term, if they are extremely high risk for bleeding, we have to expose them to very high risk, very high levels of anticoagulation during the ablation, massive doses of heparin, and afterwards their thromboembolic risk is at the highest after we cause a fair amount of inflammation in the left atrium. And we require those patients to be on a full anticoagulation for a minimum of 3 months afterwards. So I think you have to weigh that into the equation. But I think in situations where, you know, we're stuck with long-term therapy versus short-term therapy, ablation is an option to consider.
Other questions? Wow. Well, I think your noses will probably tell you that the food is there. It's a buffet. Go ahead and, yeah, round of applause for